For those of you who haven't yet met him, Diamond Fernandes is the founder and director of the HeartFit Clinic here in Calgary. And we have just recently opened the clinic in Edmonton. Already building success there, treating lots of patients. Diamond possesses over 15 years in the cardiac rehabilitation healthcare industry. And over time, of course, his interest and commitment to the field has grown. He's been featured extensively in the media as your trusted authority on heart disease rehabilitation and prevention. He's a dynamic speaker educating his audiences on various topics on heart health and is the author of the Beating Heart Disease book. You're welcome to pick one of those up if you would like to. I'm very excited. After Diamond does his presentation, we are going to have a debate between John and Diamond. So we've got some interesting topics, and I see Dr. John's up for it. All right, Diamond Fernandes.
Thank you very much for the introduction, and thank you, Dr. John, for coming from Vancouver. And you know, the Vancouver Canucks and the Calgary Flames play each other, and we always have big rivalries here in Calgary and there. But I think you have a young team there, and maybe we'll see how it goes with our debate afterwards. Thank you very much for everyone attending today. Hopefully you get some valuable information and really to prevent and reverse heart disease. And where I'm going to come from is a little bit more of a natural perspective on treating cardiovascular disease. And the title of my talk today is really treating stable coronary artery disease, and one of the treatments that we focus on is using external counterpulsation. My disclosure is I am the director of the HeartFit Clinic. I always have this little problem with how we go about understanding cardiovascular disease. And you know, is artery narrowing the problem, right? And so there are different types of artery disease out there. So there's coronary stenosis, which Dr. John talked about earlier. There's inflammation to the artery. There's endothelial dysfunction, which is early stages of disease, microvascular dysfunction, platelet coagulation, and vasospasm. So when we look at all these different types of problems that can happen from an artery perspective, yes, we're talking specifically about the coronary arteries, but I'm going to talk about, okay, well, what can we do? What are some things that we can do? Because when we open up the toolbox of different professionals out there, they have different things. And so I'm going to kind of go from that from a conventional perspective. So I'm going to talk a little bit about from following an archaic model. And I think we believe that cholesterol encroaches into the lumen, which is where the blood flows, for those who don't know what the lumen is. So that's where the blood flows. Then we end up with some kind of silent ischemia, which means there's a lack of blood flow, but you don't feel it as chest pain. Okay? And then we end up with angina, which is, hey, I'm having some chest pain, and then you end up having an infarct. And somewhere along the way, hey, you know what, if we have cholesterol that encroaches into the lumen, or if we have silent ischemia, or even if we have angina, we want to go in right away. What can we do, right? What can we do to intervene on that artery? And I'm going to talk about this model here, which some of you have seen it in our clinic before, but I'm going to talk about this as to what can we do in our model in our healthcare system. So let's first off by talking about if you're having chest pain, if you're having angina pain, if you're having pain that you do not feel comfortable with, you need to take yourself to the emergency room. That's the most important thing. Because if you are having a heart attack and you go to the emergency room, we basically want to see, are you having a myocardial infarction? Because if you are having a myocardial infarction, the number one goal, and Dr. John will agree with this, part of it is that the myocardial infarction is very important because we want to open up a blocked artery very quickly. You end up having pains associated with it. We say, okay, well, what can I do? I want to open up that vessel as quick as possible. And then we want to do that angiogram where we look right inside the coronary arteries, and we want to get a heart stent or a bypass, depending on the vessel, along with medical therapy. So my concern is, and the title of my talk was, is that how do we treat stable coronary artery disease, or how do we focus on the prevention side of things? And so when we look at coronary intervention, we have coronary artery bypass grafting, which is, you can have this debate all day long about bypass surgery versus heart stent. And everyone thinks of, okay, well, you talk to an interventional cardiologist and they'll say, well, the heart stent, I can get to this artery a lot better and quicker, which is good. But the bypass surgery might be, okay, well, I might not be able to get to that many multiple lesions or blockages. What can I do about that part of it? So, so you have a heart stent or the bypass surgery. That's really what's in our toolbox to see where cardiovascular disease risk is. And so when we look at this a little bit more closely, we're going, okay, well, what can I do at my GP level? Because what happens is that when you go to the emergency room and you say, I'm having chest pains, you get instant admission, right? And then we want to see a couple blood marker tests. They check for basically levels in the blood to see if you're actually having a heart attack. And they also look at your ECG to show if you're actually having a heart attack. But let's talk about what happens when you go back to your general practitioner or your general doctor. And there is a big gaping hole in our healthcare system, and Dr. John explained that earlier in his talk today. So at the GP level, when we open up the toolbox to see what can we see where your risk is of a heart attack or stroke, what is it that we can see? What can your family doctor do?
Blood test.
Cholesterol, blood tests, looking at cholesterol, yes? Stress test, not yet. That's more, I'll call that the next level step. Yeah, they can listen to your heart, see what it sounds like. Blood pressure, excellent, very important. Inflammation, yeah, they can look at some, some elementary inflammation markers as we learned with the pulse test. Not yet. Not at your family doctor level.
Your physical size.
Physical size, yeah, they start to address maybe overweight if you get the doctor is aggressive with that part of it. Blood sugar, there we go, that's what I'm looking for. So diabetes, right, to see where your risk is of diabetes. And so at your general practitioner level, we already established that when we plug this into a formula, it's called the Framingham Heart Score, we get a big F on that score. And what I mean by that is that the majority of people that are in the hospital with heart attacks and strokes, the majority of them have normal to borderline Framingham heart scores, some things that we wouldn't even have done anything about. And so that's my biggest concern with that part of it. Okay, well, at the GP level, unfortunately, there's not much to see in their toolbox to see where that risk is of a heart attack or stroke. And that's where the pulse test comes into play. But the big thing is that we all think that arteries are a pipe, and it's not true. Arteries are a complex muscle, like Dr. John explained, and it's a very important thing to understand, okay, well, if most people see, what happens if your kitchen sinks are plugged, right? Call a plumber, or just rotor it out. You can't do the same thing to your arteries. Actually, your arteries are a muscle. You don't want to do that same thing. So my point is that it really goes beyond checking just cholesterol, because the majority of people with a study, I believe there was 138,000 people in that study, way too many of them had normal cholesterol profile. So is cholesterol the problem, right? I'm just saying we got to go beyond cholesterol. And I'll talk a little bit about that. And then the next question is, are we focusing on the right thing? As I just got back from the Canadian Cardiovascular Congress, and I had a whole bunch of debates with cardiologists there. It was actually quite exciting. The point being is that are we really focused on the right thing? When cholesterol only accounts for maybe 5 to 10% of when we focus on that, it only makes a 5 to 10% effect change. But really, we're missing a whole 90% of the problem of what's happening. And so I'm going to get a little bit more specific with this. And some of you have heard me talk about this part of it, but there's now better drugs out there to control cholesterol, right? Where cholesterol lowering agents where we can lower your cholesterol by 74%. So if you have, to be specific, if you have an LDL profile, let's say we'll call it 4.0, if it's 4.0, we can take it down to 1.0. And in fact, in this study where they did this, I think they got it down to 0.7 if I'm not mistaken, which is almost where you're born with, right? And so we got cholesterol down to 0.7, which is exciting, am I right? From a cardiology perspective, it's like we got cholesterol down as pretty darn low. It's really good. But here's my concern with it, and this is where it goes beyond cholesterol. And so when we look at this part of it, we look at composite endpoints, which includes cardiovascular death, myocardial infarction, which is a heart attack, stroke, revascularization, which is a heart stent or bypass surgery. When we enclose all of those things together, here's my problem with it. With people that were taking the drug, 1,344 people of the 28,000, so they split them up, 28,000, 14,000 in one group, 14,000 think they're taking it. So the people that actually were taking it, 1,344 people had a problem in spite of them getting their cholesterol down to 0.7. The placebo group, who think they're taking the drug, they're like, yeah, I'm taking the drug, I'm getting healthier. 1,563 people of 14,000 in that group had a problem. So my point being is that's 9.8% of that population had a problem versus 11.3% of that population had a problem. Can anyone do some quick math for me? What's 11.3 minus 9.8?
It's not statistically significant.
1.5. It actually is statistically significant, but that's the point, is that I think we're just focusing on the wrong thing. And so if I can only save 219 people basically in a population of 28,000 people, I just think we're focusing on the wrong thing. And all the talks about, okay, well, let's just get people on a statin. Let's just lower the cholesterol as much as possible. My point is that you got to focus more on other things. And that's really where I want to get to that part of it. So there's a difference between 1,344 and 1,563. We saved 219 lives. I think my math's quick. I think I'm good there. Anyway, so when we look at the process of atherosclerosis, and as Dr. John was saying that way, we look at, artery disease starts to happen early in our childhood, right, or adolescent years. And it progressively gets worse to a point where it gets, it can grow over time. And let's just skip this part. We'll bypass it, no pun intended. And we'll go right to this level here. Cardiologists, with their testing, are only looking for advanced stages of disease, where the majority of lesions and heart attacks, Dr. John had a good slide there, which I'm going to share again here. The majority of heart attacks occur with blockages. To be precise, if we take both of them together, 86% of heart attacks occur with blockages that are less than what can be found on diagnostic imaging, right? And so with stress tests specifically, or MPIs, perfusion imaging. So when we look at this part of it, okay, well, let's look at severe coronary angiographic lesions versus mild angiographic lesions, and what can we do with this? And so when I talk about angiography, that's the gold standard for looking inside your arteries and seeing where the blockages are. And so the angiographic studies show the progression of artery disease is neither linear or predictable. And I think this slide was, I think you had this slide on there too. So I'm just repeating this. And the unpredictable episode of likelihood of cause is really the plaque disruption. So the best thing I like to say, it's like that pimple on your face. A pimple grows inside your artery, and you have that pimple that just it can stay there. Is it stable or is it not? The point being is that what's the risk of that pimple popping, right? And if that pimple pops, that's where the danger is, right? If that pimple steadily gets more and more and more and progressively starts to decrease the lumen, then that's a healed plaque. Right? And how it happens, I don't want to get into the bio and pathophysiology of that part of it, but there are different ways of actually looking at, and Dr. John explained a little bit about it as well. How do we detect the vulnerable plaque? And so yes, the pulse test is very important, but when we look at this slide, actually I'll come back to this one here, we can actually image and see what's going on inside the lumen. It's like taking a camera right inside your coronary arteries, and we can see what's going on. And we get to see, okay, well, what's the vulnerability of that plaque? And so as an image, we can say, okay, well, we got a vulnerable plaque over here. We got a lesion over here. We can see how, really it's to see how, I'm going to get a little technical here, but we can see how stent struts are positioned inside the coronary artery to make sure that we have a positioned stent appropriately. So there's all these different reasons and why we should use this, but really great imaging. But, here's the big but, when do we use it? And so with optical coherence tomography, we can actually see the lesions. And so with ST elevation MIs, that's what that stands for. ST elevation MIs, for those you don't know, it's an ECG where it's a way of us detecting if you're actually having a heart attack via ECG with electrocardiogram. Electrocardiogram is just checking the electrical signal of the heart. In my opinion, it's a waste of time doing it on someone who's not having a problem, but if you are actually, it's one of our ways to detect if you're actually having a heart attack. So that's one of the first things they do. When you call the ambulance, they actually check that. And in Calgary, we have one of the best systems to kind of, if you're actually having an ST elevation MI, in Calgary is the best place to have, not the best place, not so even bad about Vancouver, but we'll get into that part a little bit later. But we've actually established at the point that right from the paramedic level, they already are in communication with the cath lab, the angiogram, to start getting a stent in place and everything like that. So very good process. And in Calgary, we're a little bit disabled here in terms of we only have one center to do cath labs. So anyway, getting out of that part of it, really we want to say, okay, what's the risk of a plaque rupture versus a plaque erosion versus a calcified nodule? And the imaging techniques are very important and very valuable to be able to see this. So really, inflammation is the problem, and it's not plaque encroaching onto the lumen. And I'm going to talk about how we can treat stable artery disease. And there's all these different markers that we can look at. And I won't go too much into this, but your artery is a muscle. It's not a pipe. And when we look at it and understand that part of it, we want to treat it like a muscle. And that's why we can heal it or even reverse the disease process because it is a muscle. Anyone injured their muscle before? Right? How do you heal it? Over time, it gets better. Same thing can happen inside an artery. We can reduce the inflammatory response inside the artery so it can undergo a healing process. So that's that part of it. So really, if you get a clean bill of health from your cardiologist, from your general practitioner, it's important to do the protein unstable lesion signature test because it has the ability to detect unstable lesions and formations happening inside the arterial wall. And there are specific protein markers, of course, and we've already gone through this, that measure the body's immune response when there's inflammation. So I don't want to go too much into this part of it when analyzing proteins, analyzing inflammation and apoptosis and thrombosis and vascular remodeling. Those are all the different markers that we get to look at with our testing that we do at our clinic. And so really the objective is to identify individuals that have not that have been given a clean bill of health, that want to know, okay, what more can I do? Or they might be borderline risk based on a Framingham heart score. What more, how really bad am I? And then when you tell someone, well, you got a certain percentage blockage or you're in a red zone, then we know as individuals, hey, I don't want to be there. How many people want to be at risk? Nobody, right? So the point is that then we can reverse that disease risk. And so here are the different biomarkers that are associated with a vulnerable plaque. And let's go back to my chart here to talk about this part of it, because when we look at the angiograms, this is the gold standard to look right inside these arteries. We can look in the right coronary artery and the left splits off into different two. You got the anterior and circumflex. If you have a blockage, you know, there's different ways of figuring out when we should do this part of it. And so we talked about the general practitioner, unfortunately, not having much in their toolbox to see where your risk is of a heart attack or stroke. And then when we go to cardiology, you know, if you get a stress test and a nuclear test and you find yourself doing an angiogram, there's enough research now to show that do we need to go down that path? And that's some discussion that we'll have down that in a little bit. There's now some good literature showing, well, I already know that patient X has artery disease. Do I really need to do an angiogram? And there's a certain time and place where I might agree with it, and a certain time and place I might not. But I have better ways of actually treating it in our clinic, and I'm going to get to that in a little bit. And so when we talk about if you've had the stress test, I love the stress test to see if you're ischemic. Great. But I don't like the stress test because I don't like the outcome of it. Number one, either you've been given a clean bill of health, you've been told, hey, everything's fine, don't worry about it, all's good. That's where the pulse test comes into play. Or what's my opinion worse is you're going down a path to see if it's a plumbing problem. Right? And I think there's enough literature to show, okay, well, I can tell already from a stress test, do I really need to do a nuclear test and an angiogram to see the extent of the disease? When we know that medical therapy, believe it or not, is just as good as a treatment option as doing a heart stent or even bypass surgery. Now, there are different individualized cases where that might change, but now that's what the literature is showing. Do we really want to intervene on these patients because we're not seeing any changes long term? So there's the angiogram. I talked about that already, and the fractional flow reserve inside there. And if there's a problem, hey, let's throw in one of these metal tubes in there and we'll open that up, and hey, I'm a plumber, I can open your arteries up. But your arteries are not a pipe, they're a muscle. How do you heal a muscle is a lot different than how I think that we should be treating it in conventional medicine. And so when we look at this part of it, okay, well then there's bypass surgery. And it's a right instance in a certain situation. But again, these are just, we're looking for basically a supply-demand mismatch. And what happens is that we're like, okay, well let's do the angiogram and see where that supply-demand mismatch is. And we're like, hey, Mr. Smith, we have a blockage. Let's do a heart stent here, or let's do bypass surgery. Those are your two options of what we can do. And I think there's more options of what we can do. And that's really what I want to get into today. Did we question the impact on mortality or infarction by going down that plumbing path, by following that archaic model? Now, once again, I want to be clear with what I'm saying here. If you're having an emergency and you're actually having that heart attack, or what we call an acute coronary syndrome, stay in the emergency. That's important. I'm talking about when we're starting to investigate for coronary artery disease and we do find it, there are better options in terms of treating that vessel. And it's not available to everybody. But do we ever question the impact on mortality and infarction when we actually go in down and putting a heart stent or bypass surgery? So for those of you who know or have had someone that has had a heart stent or bypass surgery, we know that is palliative care. What I mean by that is it's just a short-term treatment option to help out with that. And yes, we try and maximize the life expectancy of that treatment option, but it is still palliative care. It doesn't treat the disease in terms of reversing it. If you've had a bypass surgery, and I remember this, for those of you who don't know, my father had his first heart attack at 38, and I think 42 years old he had bypass surgery. And I was just a teenager at the time, and I remember him, to this day I still remember, hey, don't worry about it. They put in a new heart. I got new arteries. I'm all good. BS on that part of it, because not so many years later he ended up with another problem. It's not a cure. And that's really what I'm trying to get at. And many people that have had heart stents or bypass surgeries should understand that. Okay, what more can I do? And that's really what I'm trying to get that part of it. So there are benefits of surgical intervention. No reduction in heart attack or symptom relief. And it's the latter. If you're struggling, and I mean struggling, with chest pain, it might be good to open that up so we can have symptom relief. But understand that's not going to prolong your life. And that sounds funny to say, but your arteries are not a pipe. And that's the biggest thing I want you to understand, is that how we treat a clogged sewer is not the same as how we treat a clogged artery. We can't just throw some liquid Drano down the pipes and we're good to go. Nor can we just say, okay, well, let's just rotor that out and hey, I'm good to go. And we have to change our thinking, and I'm a little bit different that way. We have to change our thinking as saying, okay, well, I want to know what percentage is my blocked artery, and by that means, how can I then clear this out? Doc, I want you to rotor that out. I want you to throw a metal something in there to just keep it open. That's not the treatment option. It's not the treatment option anymore. So mild to moderate obstructive coronary lesions are responsible for the majority of heart attacks, and we talked about that earlier, going through the different sides of it. When we look at this part of it, we want to really focus on the vulnerable plaque. And if you're at the end here and you have an artery blockage, how we treat it is not always how we think we should treat it. So then the question becomes, do we get further testing or do we get clean bill of health? And to understand that part of it, obviously went through the inflammation side of things. And I'm going to talk specifically about when you have stable artery disease. There's a difference between if we take a medication versus heart stent. And that was done, what is the best option? That was the COURAGE trial. That started in 2009. And there were many different trials that came out after that. But this really spurred on a lot of controversy when that came out. I don't know if you remember when that came out. But it spurred on so much controversy. It was ridiculous. Interventional cardiologists were going mayhem. And it was crazy. Like, no way. I know I can open up a vessel. That really spurred on so much controversy when that came out. I actually remember going to the CCC when that happened that year. the CCC is the Canadian Cardiovascular Congress, and so it spurred on a lot of controversy there. What about the placebo of a heart stent? How do we figure that out, eh? So what is the better option? There was the Orbiter trial that came out last year that again spurred on a lot of controversy. Well, what is there a placebo effect by me opening up my arteries? I mean, my chest pain went away just by me faking I did a heart stent? What happened was they took, I can't remember the amount of people in that trial, but two different groups. One group pretended to have a heart stent, so they went into the cath lab, they inserted the catheter, acted as if they were doing it, and then pulled it out and said, okay, we did it. Like, okay, good. And the other person group did it, and they said, okay, well, we didn't see any differences. Their chest pain magically went away. So there's a placebo effect with heart stent. And so, and that was a big media frenzy. I don't know if you followed that last year about, okay, well, this was in the, where was this? In the New York Times. Unbelievable, heart stents fail to ease chest pain. There's a placebo effect with this part of it. What about exercise versus heart stent? Now we're getting really technical here. What about the benefits of exercise versus heart stent? There was something in Circulation in 2004, a small group of people, that they showed that exercise showed more benefit than actually those people who had a heart stent. There is benefit. Why? Why? Why is this?
Exercise is a muscle.
The artery is a muscle, right? Not a pipe. The reason why it happens, and the reason why it is, and there's some other studies that came from it as well, is that exercise has got a lot of benefits to it. And so the exercise is an important part to the end. Yeah, absolutely, you can act a placebo effect on heart stent. Those patients, they again classified them in two different levels that way. And there's probably better ways of doing that, but who wants to fund these studies, right? That's the biggest thing, right? And then there's also ECP versus heart stent. And there's a lot of benefits of doing external counterpulsation. And so I'm going to talk a little bit about external counterpulsation. We use this in our clinic. This is kind of the talk I gave, for those of you who don't know, I was in Dubai in September, and this is a version of the talk that I was giving to that group of cardiologists and internal medicine that were there in Dubai. So again, your arteries are a muscle, not a pipe. And if we look at the vasculature of a coronary artery, you can see the complexity of actually the coronary arteries. And if we zoom in on an angiogram a little bit more, a little bit more, a little bit more, we would start to see it look like this. But cardiologists are not able to do anything for the smaller vessels. What we do is they're like, okay, well, let's just see where these major blockages are. And these, does anyone know the diameter of these arteries at all? We haven't really shared that. It's about the width of a quarter, approximately. Not very big, but the only thing that we can do about are things that are, because what happens with angiography and doing heart stents is they come in from this level, they insert the guide wire, and they are able to come down this artery. Now there are certain times and places when this should happen. I already mentioned if you're actually having a heart attack, we want to open up that vessel as quick as possible, right? So how that lesion looks is very important. We're only looking at the major vessel. What about all these smaller vessels, right? And what we focus on by growing those vessels is external counterpulsation. It's a safe, non-invasive, painless treatment option to really reverse the disease process by growing new vessels, improving the artery function to function like a pipe, and improve blood flow. So when we do that, so many different things happen. So I want to share a few case studies with you, a few of our patients that have done this treatment. And so here's a patient that did our treatment. His angiography report, his name's covered, of course, for privacy reasons, but he did a heart stent, he did in January 2016. So here's his angiogram. For those of you who have not seen an angiogram, here's the coronary artery, the left anterior descending, which is a major vessel because it supplies blood flow to the front portion of the heart. And so you can see this patient had a heart stent placed right here in his vessel because he had a blockage there. I want to show what happens. He comes to our clinic in the summertime. He came to our clinic 2.5 years ago. And what happens was, look at the date. That's January 2016. Same patient. And you can see the extensive of blockages and the progression of disease. So let's just see this here. You can see here, for those of you who can't see this, I'll share this with you again afterwards. Same blockages here, same blockages there. 17th of August, now this is in the summertime, he's like, I'm feeling so much chest pain, I can't believe, I'm hurting. And so what happens is there's a new lesion there that was never there before. He has some pre-stent stenosis and post-stent stenosis. That we think that angiography is good, and that person was having chest pain. There was a good reason for it to have it because it was pretty unstable for him. Is that your arteries are a muscle, not a pipe. And what happens with these lesions is a good question to ask, maybe Dr. John as well. But I've talked to interventional cardiology this, and sometimes the guide wire can cause an inflammatory response to the LAD as they pull it out. And so we end up with spontaneous lesions, they call them. And so I'm like, okay, well, that's interesting. So why would we do angiography studies if this is a possibility? And they're like, we shouldn't. We should only do it when it's an emergency. And so there is problems with this. And one of my favorite lectures to go to at the conference every year is the problems in the cath lab. And I get to see really cool things about how the arteries actually flow after and before treatments and when they shouldn't do, and they try and get lesions that they shouldn't have gotten and the repercussions of that point of it. Really, what can we do in this patient? Here's another patient, multiple blockages. What can you do? We can't, I talked to his surgeon, his cardiovascular surgeon, and he's like, okay, I got to do bypass surgery. But I'm asking him, okay, well, what are you going to bypass? And he's like, that's why I can't do bypass. And he goes, I could maybe get a couple of the lesions. I could maybe try and do this, bypass a couple of the lesions here. But what can you do? A lot of people are without hope. And more importantly, well, what can I do when I have blockages? Your arteries are not, right, a pipe. They're a muscle. How can we heal it? And so we did ECP therapy with him. This is another patient, same idea, multiple lesions, many years later, of course. So after 35 treatments of external counterpulsation, which is usually what we recommend, we've done pre and post pulse measures, and now we are our private clinic, and a lot of patients don't do a pulse test before our treatments because it is a cost. And really my goal is to help patients get to the treatment side of things really as quick as possible. So after 35 treatments, we did the protein test before, protein unstable lesions signature test before, the pulse test before, and the pulse test after. And here you can see the benefits before and after treatments with some of the patients that have done it. And in fact, this data is a little bit old. I know we've had about, I think, 6 more people that have done it on top of this, but I gave this, it's a slide I took earlier this year in a talk I did, is that we saw significant improvement, at least a 10% improvement. Ejection fraction, this is by echocardiography, where we're seeing improvement in ejection fractions. You can see improvements in ejection fractions post-ECP therapy. And there's a really good study that just came out in JACC, the Journal of American Cardiology, on ECP therapy on patients with heart failure. And again, the benefits of ECP therapy. I think in that study, they actually showed improvements of at least 10% EF in that study as well. Improvement in pulse test scores, improvement in ejection fraction, which is the percentage of blood being pumped out of the left ventricle. Here we have the endothelial function assessment, improvement in endothelial function assessment scores, which is the artery function. And so, and this is my most favorite one, is improvement in MET level. In 35 sessions, we'll be able to accomplish so much more where patients are able to increase their fitness level to a point where we have stairs coming into our place. In our old place, for those of you that remembered our old clinic, we had a ramp that came up to our clinic. And so that ramp, or now the staircases, is our way of measuring the success of what patients are able to do. They're like, I have patients who could barely walk in from the parking lot, come up the ramp, and they were done. They were done. They could not do any more. They're like, I don't even know if I could do the treatment. I'm so exhausted. These are heart failure patients, of course. But then after doing the treatments, we see significant improvement in MET levels, which is the functional fitness level that we measure. And then we compare pre and post blood sugars with patients with diabetes. Significant improvements with that part of it too. So I'm going to give you a couple situations here. Is pre-post echocardiography. We see improvements in ejection fraction. This is, again, I'm not sharing patient's name. Being is we can see territories of the heart. This is really what I want to get at. Territories of the heart. Let me give a little background to this. So when we look at echocardiography, you got number 1, which is normal. Say, tell the person next to you, I want to be normal. Number 2 is hypokinesis. okay, which means low movement. Number 3 means akinetic, which means no movement. And then you got dyskinetic, which is 4. And there's one more, 5, but we won't get into that part of it. Here you can see, this is before external counterpulsation. 4, 3, 3, 2 at the apex, 2, 3, 2. You can see that. Can everyone see that there? This is after 35 sessions. We're not perfect, so we still leave a little bit on the table. See how that territory turned a 3 to a 2? That one we were not able to change. But look at the apex of the heart. All these 4, 3, 3, 2, what we consider dead tissue to a cardiologist, we're able to reverse. I think I got a couple more here. Another one, same idea. You can see the change at the apex of the heart. We weren't able to get in this situation, but all this territory anterior of the heart, the 3, 3, 2, you can see all of them are now 1s. Still, the apex of the heart was not able to change in this patient. But at least we can track this. This is after 35 sessions. 35 sessions, they come in daily, 7 days a week, 5 days a week for 7 weeks. And this is the changes that we see right after doing with echocardiography. So another patient comes in, had a small mobile apical thrombus, 29.7% ejection fraction, severe left ventricle dysfunction. After doing 35 treatments, no thrombus anymore. Ejection fraction improved to 50-55%, which is now normal. Low normal we'll consider between 50. Most patients who have a normal ejection fraction who have not had artery disease should be above 55%. So now we've got him back to there. And now the ejection, the left ventricle function is moderately function versus severe. So we're able to change what's happening to the function of the heart. I'm a big fan of echocardiography. That's just my why. And we'll get into little talks about it, but it's a safe test to get done. And when we're talking about stress echocardiography for me is one of the best ways to see. To me, it's all about how the wall motions are moving. How is the wall of the heart moving? To me, it's not about the blocked artery, right? And to me, it's about how is the function of the heart working? That's more important, because the whole goal when you actually have a heart attack is to prevent heart failure, prevent it from being a disability. And so that's my big function. Well, how's the wall motion moving that way? So some other improvements that we see, improvements in angina, which is chest pain. Most cases we see the angina go away. We've had, I can think of numerous patients that have come on the bed, scheduled for an angiogram, and they don't do the angiogram because their angina went away. And that's the whole reason why we wanted to do it in the first place, is for symptom control. Because stents and bypass surgery are not a cure, right? They're only to, in my opinion, only to relieve symptom control versus just going in and acting like a plumber kind of thing, right? So again, we see improvements in blood pressure, heart rate, shortness of breath, oxygen saturation, energy and stamina. I mean, really great benefits from doing external counterpulsation therapy. Other noted improvements, erectile dysfunction. Erectile dysfunction, in my opinion, is a big marker for cardiovascular disease. Blood flow. The flow going to your sexual organs is a lot smaller than the ones going to your heart. And erectile dysfunction is a big marker. And we see improvements in erectile dysfunction, muscle strength, neuropathy in diabetics, color. You see improvement in color, low back pain, joint pain starts to improve. Sleep is much better. Mental capacity, clarity, hearing, vision, I hear. Singing, their singing voice improved. One of our patients said that. But we put it all in there. And hair growth, right? So that's not what we use it for. This is not what we use external counterpulsation for. It's to improve artery function. But when you improve artery function and when you improve blood flow, you start to improve blood flow all over your body. And yes, the major ones are your head. Yes, we want to minimize risk of stroke. Yes, we want to minimize your heart, risk of heart attack. Yes, we want to improve blood flow to the kidneys and your legs. But there are a lot of things that your blood goes to, right? And so this is some other benefits that we see. It's not only our focus to do external counterpulsation, that's really what makes us unique, is our education tools and what we use. And so we're big fans of focusing on exercise and nutrition, smoking cessation, stress reduction, and optical medical therapy. And sometimes a lot of patients are not wanting to be on a medication. They just don't want to be on it, or for whatever reason are getting adverse effects to being on it. I think of patients that are not able to tolerate blood pressure medications, or not be able to tolerate statin therapy, or not be able to tolerate different things. And so okay, well, let's look at what else we can do even from a natural perspective. And that's another talk for another time. But this is the big reason why we do ECP therapy or external counterpulsation, is to improve angiogenesis. Angiogenesis is one of my favorite words because it means growing new vessels, growing new arteries, right? And so this is what we really want to focus on. It's all those smaller ones. Yes, we do care about the big ones, and there's a time and place for that. I've already demonstrated that part of it. But it's really about growing new vessels that way. Here we can see this is where we focus on is external counterpulsation and lifestyle changes. And we saw this slide before. We talked about the lipid core. We want to change a vessel that is at risk of rupturing to making it more stable, right? And so the question becomes, and I've shown this slide quite a bit, is which artery would you rather have? Would you rather have it more open or a little bit less open? And the question really becomes, is a trick question because your arteries are a muscle, not a pipe. And the artery functions a lot better on the artery on the right than it does on the left. The left is actually more vulnerable to rupture. So ECP basically grows new vessels, improves blood flow, and we see significant improvements with what happens before and after with the growth of new vessels that way. I won't get too much into the data, the pictures that way. So ECP was in 2013 was in the European Society of Cardiology guidelines for the management of stable coronary artery disease. And there was also ECP reviews as a Class 2A recommendation from the European Society of Cardiology. Now, I think ECP therapy is covered in the US if it's referred from cardiology. In Canada, we're a little bit behind. I hope to change that part of it. But is artery narrowing the problem? And we've already talked about, both of us talked about it, it's not a problem, it's the risk of a plaque rupture. But when there is an artery narrowing problem, this is where it's up for debate. What is the better treatment option? And my choice always is to minimize risk to the patient and always find the least invasive way to improve heart health that way. So yes, we can focus on grades of stenosis and what happens in these different levels, but angina is really our measure, chest pain, which is how we determine the level of it. And this is really what we're going to look at. What we want to minimize is the risk of that vulnerable plaque rupture, absolutely. But if you have stenosis or if you have a blockage, my goal is to grow vessels around it. And you can do that. I've proven that. It's been proven, not just me. And cardiologists are not plumbers. That's the biggest thing I always want to talk about. And so when we're focusing on heart stents alone, and this lecture was specifically given to interventional cardiologists in Dubai, PCI improvements. We'd say, okay, well, let's try and improve the heart stent itself. Let's try and come up with better heart stents so we prevent it from clotting inside of it. Does anyone know when you have a heart stent, what do they give you as the first line of medication? Right? And why is that? Plavix is a blood thinner, for those of you who don't know. So what we do is that we've placed a metal object inside an artery. Your artery is now undergoing an inflammatory process. Right? We've put something foreign inside of your artery, inside of your muscle, not a pipe, inside your muscle. And when we put that foreign object inside a muscle, your artery doesn't like it. So we give Plavix to minimize, basically to thin the blood out, to make sure that it minimizes the clotting inside of that heart stent. And so we try and improve the heart stents, but we don't, is that a better way to do it? And we know that PCI, which is heart stents, it does not demonstrate decreased death or decreased heart attacks in patients without acute coronary syndrome. We know that. And that's a surprising stat when I tell people. And it's the pathophysiology of an artery. Do you ever stop to think about that part of it? Right? Cardiologists, interventional cardiologists are not plumbers. Right? And so the vulnerable plaque cannot be identified. That's the biggest thing. Right? We cannot detect the vulnerable plaque. When we're focusing on PCI for stable coronary artery disease, I'm going to get a little technical here. There's the COURAGE trial, there's the ORBITA trial, there's the DECISION CTO trial, which basically showed, I already talked about the top two, but optical medical therapy with or without stenting for coronary chronic total occlusion, meaning that we found a 100% blocked artery. Let me go in there and do something about it, and we found no difference in outcomes. Because it was stable. We failed to look at what that artery, what your body is doing to heal itself. The FAME trials, there's FAME 1 and 2 trials, looking at fractional flow reserve with PCI, with medical therapy versus stable coronary artery disease. And so, yes, we can look at these trials a little bit more closely, the CVL PRIT trial, but all these trials are basically showing that heart stents are not a cure, right? They're not a cure. And should we really be using them with patients who have stable coronary artery disease? That's a big thing. And the education on saturated fats. It was presented very well, and we were just talking on earlier today with Dr. Blair O'Neill, who's a cardiologist in Edmonton. He gave a talk and talks about education on saturated fat. And I think we're all educated wrong in this part of it. In our clinic, we don't talk about lowering fats. We don't talk about saturated fats because there's no fact on that part of it. There's no data to show, hey, if I give saturated fats to people, it's going to be a problem. What about the French? What about the Inuit people? We start to think about these things. Okay, well, they got so much saturated fat in their ways of eating. Why they're not having heart attacks, right? And so really, there are very few studies, if not, there are few studies that do not link the link between basically saturated fat and heart disease. I've yet to see a study that shows that part of it. What we really should be focusing on is sugar. Sugar is the big culprit here. And sugar comes in different forms. And it can come in different forms individually too. Someone can tolerate something, someone else cannot. And so nutrition becomes a big factor of debate. I'm not here to talk about nutrition today. I'll do that another day. But I want to leave you guys with this part of it. The biggest prescription to treating stable coronary artery disease is the focus on exercise. Exercise is medicine. We don't need to prove that anymore, although we can still do that. External counterpulsation, ECP, and education. Thank you very much.